Thank you very much for that introduction. Thank you everyone for being here today. I'm going to talk about meniscal transplant surgery and with a whole viewpoint on joint preservation surgery really and why it's important and where the future really lies. My disclosures are educational grants for our various teaching opportunities we have in our hospital from these organizations, but none of them have any relevance to the talk I'm going to be giving you today. Now, I'm from the UK, as most of the people from the US would like to say, across the pond. Main areas from the northwest of England. And the two main cities, or the area which we cover really, is Manchester and Liverpool. I think both are quite famous, and everyone knows Manchester for the same reason the Manchester United football club. And just down the road, half an hour, is the next famous football club, which is Liverpool related. Now, if people didn't know really about Liverpool before the World Cup recently, obviously the antics of Suarez on the field has certainly brought that into prominence, but we've got rid of him now. We'll be all happy to know. And my hospital really is bang in the middle of both of those places. It's a university teaching hospital, and it's linked and affiliated with the University of Liverpool with a large research unit and department, and we've got quite a lot of projects ongoing, mainly concentrating on joint preservation surgery. So my talk really today is to talk a little bit about joint preservation surgery. Is there a real need for it with regards to knee surgery? What are the options available? Where does it all fit in the algorithm of management of knee problems and knee replacement surgery? Talk a bit about the indications and the choice of implants we have in the meniscal transplants. And most importantly, what is the evidence? You know, till a few years back, it was still considered more experimental than with any substance. So we'll look into that as well. Now, the interesting thing is most of the data with regards to osteoarthritis, since we've heard from yesterday, shows that osteoarthritis is on the increase, especially joint, weight-bearing joints, hips and knees are taking the brunt of it, and the figures are staggering. Another interesting thing is trying to get a lot of data with regards to the replacement surgery itself. Here from the US is a lot more updated than we have in the UK. But the staggering figures show that there was 129,000 total knee arthroplasties done in 1990, and this increased to about 600,000 by 2010. And the projection analysis show that in the next 15 to 20 years, this is going to further increase all the way up to about 3 million. And that's a staggering number. And there's various reasons for this. One obviously is overall aging population, and we have to meet that with regards to the arthritis that it presents with. And secondly is patients getting more and more obese. And again, that's something that is directly related to arthritis in weight-bearing joints. I think another phenomenon is this group of patients presenting a lot younger with post-trauma, either regards to knee injuries, fractures related to sports, and hence having a lot of degenerative changes. So we're seeing a lot of younger patients with arthritis. Bhandari et al. Came up with a very good paper, actually. I don't know if you've all come across this, published in 2012, where he actually broke down with regards to different management options for arthritis and gave them sort of a cost analysis. Obviously, there is an increased cost with joint replacement surgery, including either partial knee replacements or total knee replacement surgery. But I've concentrated on this mainly on revision total knee replacements. And about 55,000 of revision total knee replacements done in the US in 2010, which is a huge number. Out of this, most interesting fact was 48% of these revision surgeries were under 65. All right, now 65, whether physiological or chronological, is a young patient. And if they're having revision surgery, 48% having revision surgery at that age, you can imagine, what the next sort of steps are going to be. And the costs associated with this are even more staggering. There's $49,000 for a revision operation, mainly hospital costs, let alone community or any other sort of, allied professional health costs that are associated with it. And this is going to increase up to about 2.7 billion per year. And by 2030, 13 billion. So it's a huge cost, to the economy overall, let alone for the patients itself. So all this data really points to one thing, is that we need to come up with new solutions, with new options with regards to treating and managing arthritis, treating and managing early arthritis, and hence trying to delay the onset of partial knee replacement surgery, total knee replacement surgery, and eventually a revision knee replacement surgery. And at the same time, though, we have to efficiently manage patient symptoms. So all this has to come at a sort of added benefit of having improved function and improved pain, because these days patients have got, unrealistic expectations. They want to get back to be doing things a lot quicker. They want to get back to doing things without having too many problems. So what are the options available at the moment with regards to joint preservation surgery? I've just highlighted a few options, and then we'll concentrate on the meniscal transplant. One is osteotomies, so high tibial osteotomies or distal femoral osteotomies for mainly medial or lateral compartment arthritis is an option, especially for alignment correction. And majority of patients in this are about less than 60 years. Well, you've got to look at the literature, and published evidence depends on where most of the data comes from, but overall about 60 to 70% good to excellent results at about 8 to 10 years. So the important really in that is you're managing them and buying them 8 to 10 years before you're trying to sacrifice their joints. So they've still got the native joint, they've still got the ligaments, they've got the proprioception, they've got the menisci, so that helps with overall function and rehab afterwards. But another important or very interesting fact was only 1,040 high tibial osteotomies were done in the US in 2010. That is a hugely low number compared to, European counterparts, which are doing a lot more. I don't know what the reason for that is, but it'll be interesting to sort of talk to some lower limb surgeons about it. Now, there's a couple of pictures just to show what we actually do with correcting high tibial osteotomies. Basically, open wedge osteotomy, correct the overall alignment, a bone graft if required, and the main aim really is to shift your weight-bearing axis to get it more central or a little bit more lateral so it offloads the medial compartment. Important thing, like I said, is you leave the ligaments intact, you leave the native joint intact, proprioception is intact, so overall function is better. The other options are knee resurfacing surgery, which are starting to come about, mainly in the last 7 to 8 years. The data about this is still not fully out there, and we don't have long-term results in studies, but we have good 5 to 6 year studies. Now, these are mainly for localized, isolated cartilage defects who maybe failed microfracture treatment, who maybe failed osteochondral graft treatment. And the next step, easy step, is to try and push them into a unicompartmental knee replacement. But knee resurfacing sort of bridges that gap. It's more of a localized lesion where you can address it, buy them maybe 5 to 6 years currently in the data, which I personally think is probably a little bit more than that. And there's various different implants available. The hemicap option and the unicap option and a biopoly, which has been more recent in the last 3 to 4 years. Again, this is just a buying factor, buying them time, trying to delay any joint replacement surgery. Now, with that sort of joint preservation surgery options, the next one is meniscal transplant surgery. Now, meniscus, we all know, is a fibrocartilaginous structure. Main aim is a shock absorbency disc in the knee, spreads the force around, protects the cartilage. And main other sort of side functions it has is a secondary stabilizer, proprioception, aids a little bit in lubrication. Now, meniscal tears are by common, the most common injury that most orthopedic surgeons will encounter. And partial meniscectomies is by far the most common operation orthopedic surgeons will do. Whether rightly or wrongly, if you see a meniscal tear, the general knee-jerk reaction is, let's take it out. All right? Very rarely people will repair it. Obviously, it has other factors to do with it. But most patients end up having partial meniscectomies, subtotal meniscectomies, or sometimes near-total meniscectomies, where you've pretty much taken out the whole meniscus. So what are the consequences of this? The consequences of this is your protective layer or the function of the meniscus is lost. Studies have shown that your cartilage forces that go through the joint, once your meniscus is lost, is up to about 350%. So that starts wearing out your cartilage, wearing out the joint surfaces, and you have increased arthritis. We have well-established evidence now in literature and published work that once you've lost your meniscus, you have increased forces in the compartment, you start getting degenerative changes in that joint. In the lateral compartment, is less forgiving. In about 6 to 7 years, you have pretty much established arthritic changes. Medial compartment is more forgiving, it takes a bit longer, but again, 9 to 10 years, you start having established changes. And there's very few options available in this sort of subgroup of patients, where you have patients who've had meniscectomies done in the past, come back to your clinic 2 to 3 years' time with some pain in the cartilage. Majority of them are told, well, we can't do anything now, you've got no further tear, you've had an MRI scan, you go away and you wait. You wait for another 5 years, wait another 6 years, wait another 10 years, till you have full-blown arthritis, then come back, we'll do a joint replacement surgery. That's what's basically told to most of the patients in most centers. That's just giving you a picture, arthroscopic picture of a meniscectomy that's done. This defunctions the meniscus. You start getting point loading in that area that starts spreading, increased cartilage wear and tear, whole biomechanics of the joint is lost, and you start getting a failing joint in that compartment. So what does meniscal transplant surgery do? What it does is it preserves or tries to reconstitute the function of the meniscus itself. And there's various different ways in which it does this, and we'll touch on 2 of them. But what are the grafts we use? We normally use either synthetic scaffolds, right, which are biodegradable grafts. These are mainly for isolated defects where you still have the rim intact, you have the anterior and posterior horns intact. If you had the whole meniscus gone, you haven't got anything structurally there to fix these biosynthetic scaffolds, then you need to move on to the next step, which will probably be an allograft implant. And that's mainly for total or subtotal meniscectomies. The patient group indicated in most sort of studies that we've come across is basically between 20 to 45 years, who've had an injury, who've had a previous arthroscopy, who've had a meniscectomy performed, come back to your clinic presenting with unicompartmental pain in that compartment. Cartilage loss has to be minimal, so you're looking at IRCS grading of about 1 to 2 rather than 3 to 4, so it has to be early degenerative changes. And again, the prerequisite is your overall alignment has to be fine and the knee has to be stable, so all your ligaments have to be functioning, otherwise there's a higher failure rate. So the inclusion criteria is quite strict, but majority of our patients, if you actually think about the ones we see, fit into that criteria, fit into that category. So a little bit about the implants itself. There's 2 main ones in the market now, which most of the research and studies are done with. One is the ActiFit, which is a biodegradable biocomposite polymer, and the other one is a collagen-based one, which is a CMI-based scaffold. Pretty much do the same thing, and what they tend to do is you're trying to cut them out to size, shape them into the defect they have, and you suture it together, all right? And the main aim is, once this is done, it reconstitutes the function of the meniscus, so the load-bearing capacity is pretty much restored, and in time, as you sort of go into 6, 8 weeks, 3 months, you start having reconstituted growth of meniscal tissue into the scaffold. And in time, most studies have shown, when they've taken biopsies of that, is you actually have proper meniscal tissue in growth into the scaffold itself. So it reconstituted the meniscus, really. Now, what about for patients who have lost pretty much most of the meniscus? The options really are allografts, because you can't restitch that biosynthetic scaffold onto anything else if the whole meniscus is gone. So allograft really is the mainstay for these patients. A little bit less with regards to the overall evidence available on this, and most of them come in sort of bone blocks, and they're sized either on x-rays or on MRIs, and you actually self-ordered this and as a specific size and specific side what you need, lateral or medial meniscus. And there's various ways in which you fix this. You can either use bone blocks from the 2 ends, drill bone tunnels similar to what you do with the ACL, implant the graft in, and stitch it around and suture it across all the way around. So what is the evidence available? Now, we did a detailed literature search trying to elicit all these different facets of areas in the literature to try and see what is published and how good these grafts really are. So what we really looked at was pain reduction, improved function, quality of life, tissue ingrowth, failure rate, reoperation rate, and lastly, chondroprotective effects. Now, all these are basically constituents that you'll be doing a graft for, so we need to try and look at in the literature if all of these are being addressed and what the results really are. We tried to look at mainly randomized controlled trials in all the research databases that we used. If we didn't have any of those, we looked for long-term comparative studies, and if not, long-term follow-up studies. The problems we really faced is the literature is very, very poor in this area. There's not many randomized control studies available, very few comparative studies, and even fewer long-term follow-up studies. There's various different patient and surgeon factors and variables that are poorly recorded in all the data that's been published. The degree of arthritis has not been properly documented, so we don't know what grade they've used with regards to the IRCS grading or any other arthritic grading. Type of graft used, again, is not specifically identified. Fixation is not, again, specifically identified, and all these have a factors and bearing, really, with regards to your graft failure. Concomitant procedures, again, which is very important, such as high tibial osteotomies or ACL reconstructions alongside, have been done very differently, so you can't really compare like for like. You can't really compare the grafts for other grafts in different areas because of the other concomitant procedures done, because you don't know what the effect is due to. And lastly is the outcome measures have been very poor with regards to, pain analog scores. They've been documented poorly. They've not been standardized. Other areas which are, regards to your functional scoring has been poorly documented. Everyone uses different ones. So it was a very, very difficult job to try and tease out the literature and what is actually there to make any meaningful sense of it. So with regards to pain, firstly, we found one RCT with about 311 patients, and this was split into 2 groups. One group having had meniscectomies and arthroscopy in the past, and the other one hadn't. And then they basically compared the biosynthetic scaffold compared to meniscectomy patients with regards to their pain overall. And what they said that they had better pain scores in the implant group. The second group in the patients which actually have had previous meniscectomies in the past, they really didn't find any difference in that, okay? The other 2 long-term study papers, which were more than 10 years, because we tried to find out most of the papers which are 8 and 10 years plus to try and get some meaningful results and data from it. Both of these by Monilau and Zafagini showed that they had improved pain results compared to the preoperative levels. What about function? Function, we found one good RCT of about 60% of the patients, 60 patients, sorry. And they split into two groups. One was high tibial osteotomy alone, and one was high tibial osteotomy with a biosynthetic implant. And their results showed that the functional levels of patients who had the implant with the HTO were better than just with the HTO themselves. And again, the functional from the previous two papers included the function as well as the pain, and again, they showed improved function in both those long-term study analysis compared to the pre-op levels. Quality of life, there was only one paper we could find, which was non-randomized, a comparative study, which was a small population of only 33 patients. They used an SF-36, and in that paper, they did conclude that the scores were better with regards to the quality of life improvement. Tissue ingrowth, again, only one relevant decent study we found, which was done here in the US. It was a multi-center trial, over 16 sites, 26 surgeons involved, and they showed a 90% of ingrowth into this biosynthetic scaffold. Failure rates and reoperation rates, again, is very interesting, and we need to look at this very closely to actually see if this is worthwhile doing. Again, not very much data on this. With regards to failure rates, we had a case series, two case series, one with 52 patients, one with 25 patients. But they were long-term studies, and they did show about 7 to 8% failure rate. This included for infection and for any mechanical failure, so dislodgement of sutures, further tears, or any graft failure itself in the early phases of the study. The reoperation rate, again, the initial RCT I talked about right in the beginning, covered this quite nicely, and they had data and reoperation rates at 5 years, and what they used as their sort of criteria was persistent pain in that compartment that needed a reoperation, or any mechanical symptoms given, such as locking or giving way or anything else like that. And with the implant group, again, this was favorable. Only 10% of the patients had a reoperation rate compared to 23% of the patients in the meniscectomy group. Now, lastly, with regards to chondroprotective effects, there's not been much in the evidence with regards to biosynthetic scaffolds that show any sort of logical overall function or improvement with regards to chondroprotective effects. Now, these are all the literature with regards to the biosynthetic scaffolds. What about the allografts? The allografts, there are no randomized controlled trials or comparative studies in the literature to date. Most of them are long-standing follow-up studies, mainly done from either here in the US, Canada, or Belgium. Verdonk is a big name with meniscal transplant surgery, and he's got the largest, most sort of authentic series, if you like, with least amount of follow-up lost of patients. His series of 96 patients with 100 allograft procedures showed a 70% improved function and pain rate at 10 years. Wirth et al. Had a smaller series, but a very long follow-up, and he unfortunately did not show much difference with regards to pain or function compared to the pre-op and the post-op. Very difficult to ascertain why that was, but I think his series numbers was quite small. Now, Cameron et al. From Canada, I think he's got the largest series of allograft patients. He did his procedure open compared to the others who've done it arthroscopically. And he had 10 to 12 years, had a follow-up of 125 patients showing good to excellent results. This, again, is in the domains of pain and function improvement, really. There's lots of other evidence in the literature with short and medium-term follow-up with allografts, so up to about 5-6 years, which are all showing encouraging good pain and function levels. But again, these are just about 5-6 years. The only other one with regards to chondroprotective effect was a Verdonk series. I think it was a subset from his previous work, which showed the MRI scans done at about 12 years showed no further deterioration in the cartilage in that compartment. So it showed some good chondroprotective effect. So what were our conclusions from this was there is obviously a lack of decent evidence out there with regards to published literature. But from what we could tease out from the published available evidence was that both biosynthetic scaffolds and allografts have shown improved function and pain levels as a predominant main end factor, and this is at least reproducible up to 10 years in most of the series we've seen. The failure and reoperation rates are low and acceptable, which was 7 to 8% were the ones we got with most of the figures. And there are potential chondroprotective effects shown, especially with the allograft series with Verdonks from the Belgium area. Hence, meniscal transplants are an important treatment modality and option for joint preservation surgery because they do give improved pain, they do give improved function, maybe not 100% improved chondroprotective effect from what evidence is available, but if it can buy you 10 to 12 years, it delays your surgical joint replacement options, either partial knee replacement, total knee replacements, and for sure revision knee replacement surgery. Most of the research in our unit at the moment is going into trying to construct proper randomized control trials for this, and I think we need to concentrate on trying to get some survivorship analysis as well, similar to what we have with joint replacement surgery, with meniscal transplant surgery as a modality, and concentrate a little bit more on cost comparison analysis to try and see how much cost saving we're actually doing, buying these patients the amount of time we are. Thank you.
Any questions?
There's a question in the back.
Thank you, Dr. Fahad, for your great expose. I would like to ask you, do you know why there are more young people with arthritis discovered? Without, do you know the etiology or?
I think most young patients we're seeing with degenerative changes are post-traumatic. You know, patients who, because they're involved in a lot more sport, a lot faster, they've had ACL injuries, they've had cartilage defects, cartilage injuries, they've had meniscal tears, traumatic sort of lesions that are left, and hence you start getting increased degenerative changes in the joint as time goes on. Most of these are treated initially with either an ACL reconstruction or, you know, meniscectomies, but they're not really followed up after that for, you know, pretty much long time. So when they come back to your clinic maybe 6, 7 years down the line, they've probably started already having some established degenerative changes, and then they fit into the category of an arthritic patient rather than a sports injury knee patient. And I think that's the trouble really, because we're seeing a lot more of those patients coming in. We're starting to see a lot more degenerative changes in that subgroup of population.
I have a question. So the biosynthetic meniscal sort of grafts are really not used in the United States, and allografts are, and I wondered if you could speak on that, why you think that is. Transplants tend to be more allografts in the U.S., and sort of what might be the impetus of why we aren't doing more of this if the outcomes are. Second of all, do you think that we're getting adequate failure rates, just reoperation versus imaging, and your recommendations on that for protocols to follow these patients? Because I think we're under monitoring them, so we're calling things successful, and the question is really what is the long-term outcome we're trying to prevent or improve?
I think firstly, with regards to your first question, with regards to what graft you're using, I think in the US it's a lot easier to obtain an allograft. Yeah. It's a lot easier to obtain.
It's crazy.
And it's cheaper. I think the same with ACLs as well. You see a lot more allograft ACLs being reconstructed here compared to Europe. I think that is the one big mismatch we have, because for us in the UK, as opposed to most places in Europe, it's very difficult to get an allograft. And hence we try and make do and try and use a lot more synthetic stuff that we can. I think that's the one sort of main reason. But saying that, I think most of the other literature and data we have now on biosynthetic scaffolds actually doing well, and we're starting to have more 10, 12-year results on them. I haven't
seen anyone use
I think, no, there are a few centers I think in the US are using it, but again, it's not as much. I think for the simple reason is that allografts is a lot more commonly used because it's more available here, and they tend to be, that seems to be the default compared to using. Can
you speak on the cost difference though?
I think cost difference in pounds, if you're getting an allograft, if you order one in the UK, is about £3,500, which is what, about just over $5,500. For the synthetic scaffold, it's 2,000. So you're saving about £1,500, you know, pretty much up front, which is almost half the cost really. And I think that may be the main reason why. Now coming back to your second question, with regards to your imaging, you said, with most of the studies that we have are following up patients with MRI scan imaging, which Verdant did, and most of the others use X-ray imaging. But I think both of those are pretty much, I don't think they give the whole true picture of what's going on. And I think it was very interesting speaking to Dr. Dye yesterday, who talks about the whole knee homeostasis mechanism. And I think it may be that once you've done a meniscal transplant and the knee settles down, doing a bone scan and actually seeing actually there's nothing more going on there may be the way forward, you know, for future research. So I think MRI, as we all know, you know, it doesn't give you the whole picture. Sometimes you see the degenerative changes there, which are not predominantly till you actually open the patient up, and it's a whole different scenario. So I think the overall sort of modalities with regards to treatment management, again, needs investigating further and need looking into. But you're right, I think we're not, you know, we don't get the whole true picture with regards to what's available at the moment.
I have a question in the end, but one constatation too. A colleague asked about why so many arthritis, because I think because we want to return the sportsmen too quickly back to the competition. And because everyone wants to go recreational sports to go to work and everything. So if you have ACL rupture, then you go in reconstruction, then to the ACL and meniscus too. If you have just a meniscus, many times you do resection, partial resection, because the sportsmen don't have a time. We have some studies that after a lateral meniscus resection, you can go to the play football between 7 and 8 weeks, and why not the suture the lateral meniscus? But we know we have some reoperations between 10 and sometimes 40% after repair, and it could be a very big problem for the sportsman and the director of the club. It's true. So on the other side, I have a question for you. You have a very nice lecture for us. What is tell some about the rehabilitation after meniscus reconstruction with scaffold?
Now, with regards to the rehab program, everyone again uses it differently. Most surgeons you speak to, even you speak to Verdong, Tim Spalding, or main sort of high sort of stream surgeons, they do it differently. I use the same rehab program for both of my meniscal allograft transplants as well as the biosynthetic grafts. So they go through a proper structured protection program with a touch toe weight bearing, range of motion restricted from 0 to 30 degrees and increased by 30 degrees every 2 to 3 weeks. So you're overall looking at about 8 to 12 weeks before they start having any flexion and start increasing full flexion and full range of motion and full rehab. I protect them for at least 3 months really overall with regards to gradual increasing, you know, with weight bearing status and with range of motion. Because I think they need that much time just to get things going. There's a few percent of patients that, you know, sports people, especially younger people who go and they want to start getting back to doing things. And if they don't follow the program, I don't do the operation. I sort of tell them, you know, you've got to follow the rehab program. My physio sit through it. We have a joint clinic alongside each other. And it was the same with most of my other work with ACLs as well. If they don't wait till 8 months, you know, I don't operate on them. Because most of them want to get back to doing things. And ACL is a prime example. By 3-4 months, they normally feel fit. They feel well, knees stable. They want to get out and start playing. And, you know, they end up in failure rates. So for me, I do a long protection program, at least 3 to 4 months before they start, you know, full rehab and, you know, weight training and sports training. But I think they need that much time. They need 3 months for the meniscal to embed in, for them not to have enough stresses going through.
Any more questions?
One last question for you. Who do you, you know, these patients have to be obviously well selected. Who do you think and how do you recommend this procedure to who? Because we see a lot of meniscal tears and a lot of meniscal pathology, and maybe you can help us identify who you think, because I think the outcome results have been based on that.
Yeah, it is. I think the main sort of patient selection group is patients within that age group, although it's not strictly that age group, it's more physiological age group I use. But majority, 80% of my patients fall into that age group of 20 to 45. Now, when they've had previous meniscectomies, where it's well documented how much meniscus is taken out, it's either someone I know, someone I trust, or I see a good op note from, you know, where they've been referred to me. And they have to have some pain in that compartment afterwards. If they come back and say, well, I'm fine, I'm doing well, I don't have any pain, I don't operate on them because I don't think prophylactically there's enough evidence out there to say if it makes any difference or not. So you need to be operating. And it does come with risks as well, with the failure rate, the reoperation rate, so you need to be sure on that. So they have to have some pain in that compartment. They have to have cartilage loss of either 1 to 2 grading. Anything more than that, results show that they don't do well. So it has to be low cartilage loss in that compartment with regards to ICRS grade 1 to 2. Thirdly, and most importantly, knee has to be stable. So they have to have a functioning ACL. They have to have overall alignment is good. So they all have alignment. If they don't have those two, they're not contraindications, but you have to address them at the time of surgery. So if they're in a varus, you've got to do a HTO to try and correct that. And if they have an ACL deficiency, you've got to do either a staged ACL reconstruction, you know, let them recover from that, and then do the meniscal transplant. So those are my sort of fixed criteria, really. Third is the knee has to be stable, so the ACL has to be working and functioning, and the overall alignment has to be adequate.
You can do full concomitant operation.
Yeah.
You have to fix everything.
Yeah.
Otherwise, you have a problem in 2 years.
Yeah, I think it's more sort of in a patient-specific approach, really. You've got to address, you know, what the main problem is.
Thank you. Should we be able to break for lunch now?
Okay, thank you.